My talk today is about emerging drug-resistant HIV. Right. So, of course, we have to start off with some statistics about HIV infection in the world, and stats from 2016 from UNAIDS and WHO indicate that, in fact, globally 36.7 million persons are infected with HIV. And during 2016 alone, in fact, 1.8 million people across the globe became newly infected with HIV, and still 1 million deaths occurred because of this infection. No, was it? As everyone in this audience well knows, the majority of the burden of this disease, in fact, is in Africa, with 2/3 of global infections of HIV residing in Africa, or estimating about 25.6 million persons. Why am I doing this wrong? Antiretroviral therapy has been available since about the late 80s, and many drugs have been developed over the time and are classed into the mechanism of action. So, for instance, the chemokine receptor antagonists and the fusion inhibitors prevent entry of the HIV virion into the infected cell. The reverse transcriptase inhibitors, where the nucleoside or non-nucleoside prevent the action of the reverse transcriptase enzyme. Of course, the integrase inhibitors prevent the action of the integrase inhibitors. And, of course, your protease inhibitors prevent the maturation process. Can I do this? The first antiretroviral was, of course, cidovudine, which was developed in 1987. And since then, a number of therapy options have been developed. In fact, some of them even being developed and licensed within the last year or two. No, why am I fighting with this thing? Sorry. Okay. It's just moving by itself. Okay. So most ART options are available. In fact, it's just moving, so can I do that?
You couldn't use that.
That one? Okay.
Oh, the spacebar.
Spacebar. Sorry. And in first world settings, most therapy options include a cocktail of these drugs in whatever formulation the clinician chooses. Often, supported with a lot of diagnostic testing, including resistance testing where available. However, in first world settings, generally we followed standard. In third world settings, low middle income countries, we generally follow standardized algorithms for treatment options recommended by the World Health Organization. So, for instance, for first-line treatment of HIV, the WHO recommended options are, in fact, 1 non-nucleoside reverse transcriptase inhibitors plus 2 NRTIs. Fortunately, the combination of efavirenz, intracitabine, and tenofovir is available as a single tablet. So at the moment, we are doing what is known as test and treat. So every HIV person globally who is infected with HIV, and obviously upon diagnosis, then is eligible for treatment. And viral load monitoring, where available, is then done at least annually. Resistance testing is very limited in your low middle income settings, and generally certainly not available at start of treatment or, in fact, at first line failure. If 2 successive viral loads indicate that the patient is failing therapy by means of a viral load greater than 1,000 copies per mil, the patient is then switched to second line. So in second-line therapy, what we do is we keep the emtricitabine, we swap the non-nucleoside, the NNRTI, with a protease inhibitor. It's generally either lopinavir or atazanavir. And we either swap tenofovir with cidovudine, or we keep tenofovir if the patient has got HPV, and add in that cidovudine as well. Again, viral load monitoring, probably once a year. Again, if the patient then proceeds to fail this regimen with 2 viral loads, consecutive viral loads greater than 1,000 copies per mil, where available, this patient then is eligible for third-line options. Third-line options are generally not standardized across these settings, but for instance, in South Africa, there is a third-line committee, and people can access these regimens where required. Again, resistance testing in South Africa is available at second-line failure only, and in fact is a requirement for third-line prescription. So, as I said, ART has been available for 20, 30 years, but it's generally only since WHO and UNAIDS launched the 3x5 campaign in the early 2000s that, in fact, ART provision globally was massively scaled up. And recent stats, in fact, they indicate that probably about 50% of people across the globe that are infected with HIV are, in fact, receiving antiretroviral therapy. So there's been a massive scale-up, an extremely successful scale-up, and everyone in this audience, of course, knows the benefits of ART provision in terms of reducing mortality and morbidity. In 2014, the UNAIDS launched what is known as the 1990 campaign. And in this campaign, some targets were set, which very simply are as follows, that by the year 2020, all HIV-infected persons globally need to know their status. Of these, 90% of them must be receiving antiretroviral therapy, and of these, 90% of them must be virologically suppressed. These are very ambitious targets. I think they're very exciting, and it's very good to have targets to work to. But of course, in order to successfully achieve these targets, we've got to assess where we are. So again, global data from WHO and UNAIDS indicates that we're actually quite far off from achieving these targets. So estimates that, in fact, that another 7.5 million people need to become aware of their HIV-infected status within the next 4 to 5 years. Another 10 million people globally need to receive ART. And again, another 10.7 million people need to become virologically suppressed. So still quite a way to go. So this is what is known by the UNAIDS as the fast-track approach. So it's basically we need to massively scale up antiretroviral therapy provision across the globe. This is a very busy slide. I'm not going to go through it in detail, but the basis behind this is that, in fact, if you see in the red here, in the comments at the bottom, that if we don't do this massive scale-up of ART provision, in fact, the HIV or the AIDS epidemic will, in fact, outrun the measures that we put in place at the moment, and in fact outrun the response, increasing the long-term need for HIV treatment and increasing costs. So therefore, this massive scale-up that is being recommended by UNAIDS is essential to prevent HIV prevention and treatment approaches that will enable the response to outpace the epidemic. Anyway, I'm here not to talk about HIV, but in fact to talk about HIV drug resistance. So HIV resistance occurs when mutations or genetic changes occur in the genome of the virion that basically render the virion now able to replicate in the presence of the drug. So HIV resistance occurs very quickly because the reverse transcriptase enzyme has an extremely high error rate, and HIV in an unsuppressed environment has a very high rapid turnover. So in other words, 10 to 11 virions are in fact generated per day. So since in fact resistant HIV was identified in the late 80s, international efforts have been in place to in fact develop quite an extensive knowledge of HIV drug resistance mutations and the impact that they have on the different therapies. These mutations are then summarized. Generally, probably what is the most well known, in fact, is the International AIDS Society Drug Resistance Mutation List, which is published, or if not updated, at least once a year, and normally published in topics of antiviral medicine, and has also led to the development of a number of databases that are, globally available. I'm showing here, in fact, what is known as the Stanford Resistance Database, that most people that are doing resistance testing use this database to take some sequence data and get a phenotypic response or an outcome response as to what drugs the sequence is now resistant to and what drugs it's susceptible to. This has also allowed for massive collaborative efforts to engage in research just to understand what the patterns of HIV resistance development are. So a few things we do need to always remember when we're talking about HIV resistance. So firstly, drug-resistant variants are selected during treatment failure, but drug-resistant variants similarly cause treatment failure. These variants may compromise variant fitness. We also have what is known as cross-resistance. So, for instance, drug resistance to a single member of a drug class generally brings about resistance to all members of the same drug class. For instance, if a patient fails efavirenz, the patient will, of course, and develops resistance, the patient will become resistant to all NNRTI drug class members. Okay. The different drug classes have different genetic barriers to drug resistance. So, for instance, your NNRTIs, generally a single mutation is required to confer high levels of drug resistance, whereas in your protease inhibitors, your integrase inhibitors, a sequential accumulation of resistance or mutations are required in order to develop high-level resistance. And thirdly, of course, and lastly, drug-resistant mutations can in fact fade in the absence of drug pressure. Right, so let's get on to the epidemiology of HIV drug resistance. When we sort of do epidemiological studies, we need to consider that drug resistance occurs by one of three mechanisms. Okay, so we talk about acquired resistance, which is the development of resistance during non-suppressive treatment, or in other words, secondary resistance. We also talk about transmitted resistance, and that is when a patient becomes newly infected with a drug-resistant variant. And recently we pay more attention to what we call pre-treatment resistance levels. So these are levels of drug resistance in the patient that is about to initiate therapy. Okay. Whether now this in fact pre-treatment resistance could be a result of being in care or being on therapy in an earlier time point, going off therapy and starting treatment again, or in fact or it could be as a result of transmitted resistance. But the point is that this patient is now resistant to the regimen that it's about to receive. So what do we know the global epidemiology of acquired drug resistance? So a number of studies have taken place over the last few years looking at patterns of resistance in patients failing NNRTI-based regimens, and generally the patterns are the same. So the first mutation to appear is what is known as your M184V mutation, which confers resistance to 3TC and FTC, followed then quickly by development of resistance to NNRTI drug class, and then thirdly followed by resistance to your NRTIs. And you can see here in this graph what we have here plotted. In the black line is virological failure, followed very quickly by 3TC resistance, and an NNRTI resistance, and then much later by your NRTI resistance. So you often see this pattern in your cross-sectional studies. 80 to 90% of patients failing NNRTI-based regimens have RTI mutations. Most common is your M184V, followed by your NNRTIs, and then later your NRTI mutations. What we have noticed over the years is as standardized regimens have changed, so the patterns of NNRTI resistance have changed. So, for instance, here in the white graph is patients failing D4T or stabudin-based regimens. In the black bar here is tenofovir. As you can see, however, so M184V is common to both, but your K65R mutation is a lot more common in patients failing a stabudin-based regimen, failing a tenofovir-based regimen as opposed to stabudin. In this bottom graph, we have efavirenz in your white bars, and nevirapine failure in your black bars. As you can see, V106M mutation is a lot more common in efavirenz-based failure, whereas your Y181C mutation is more common in nevirapine-based failure. What we do also know is that the longer patients are kept on a failing regimen, so more mutations accumulate. Okay. So, for instance, this is in fact data from an Ethiopian study showing very clearly at time 0, time 1, time 2, time 3, the longer patients are kept, so more mutations are kept on a failing regimen, so more the mutations accumulate, in fact, into both drug classes, your NNRTIs and your NRTIs. We see similar patterns in terms of second-line failure, so a very nice meta-analysis recently published by Andrew Stockdale, showing again the longer patients are kept on a failing protease inhibitor-based regimen, so more PI mutations accumulate over time. So very clearly, the longer they are failing, the more the mutations accumulate. What we are, however, seeing is a very different and very opposite pattern in your high-income countries. So in fact, this is from the UK Drug Resistance Database, showing very clearly over time, firstly to any class, to NNRTIs, and to PIs, that in fact in the UK, acquired drug resistance is definitely on the decrease. Okay, some epi of transmitted resistance. So in 2012, the WHO Global Drug Resistance Report showed in first analysis that levels of transmitted resistance are certainly on the increase. This graph, in fact, very clearly doing a meta-analysis of the studies that were submitted to the WHO, showing the longer time since ART rollout, so the increase in levels of transmitted resistance. Okay, and again, similarly shown in a recent publication from Sunyon Ring at Stanford University, very clearly showing, again, with years since ART scale-up, that overall transmitted resistance in sub-Saharan Africa is definitely increasing, as well as your NNRTI resistance. Okay. Just a quick analysis of some data from South Africa in KwaZulu-Natal, from the three graphs here, 2010, 2011, and 2012. Very definite increase in levels of transmitted resistance, in fact, over the 3-year period. Again, not the same pattern we're seeing in high-income countries. Okay. This graph over here is, in fact, data from the US, very clearly showing that transmitted resistance is decreasing in the US. This graph here is data from Europe. This is the Eurocord cohort. Again, definitely decreasing. And similarly, the UK database as well, showing that levels of transmitted resistance in all of these regions are decreasing over time. So this last little blurb I've got at the bottom here, again from the 2012 WHO Drug Resistance Report, indicating that at the time of the report, about 10 to 17% of ARV, of treatment-naive individuals in Australia, Japan, US, and Europe were at that time infected with a resistant strain. However, the proportion, and I note here, the proportion of people achieving treatment success or viral load suppression has increased over time, thus reducing the emergence of acquired resistance and subsequent transmission. Why do we need to worry about transmitted resistance? So this data here from Linda Wittkop, very clearly showing that in fact the presence of transmitted resistance to the treatment regimen that you are about to initiate significantly reduces the chance of achieving virological success. So we have over here the black line, which is your patients achieving virological suppression. This is obviously no transmitted resistance. In the blue line, we have transmitted resistance, but to another drug class. Whilst in the red line, very different, very clearly showing the increased risk of virological failure. And that is patients that are infected with a resistant strain to the regimen they are about to start on. Pretreatment resistance. As I mentioned earlier, pretreatment resistance is a combination of probably whether it be acquired resistance and falling out of care and then coming back into the treatment program, or whether it's transmitted resistance. It doesn't matter how it happens. The point is pretreatment resistance is a measure of resistance at time of treatment initiation. And this data here, in fact, from the 2017 WHO drug resistance report, very clearly showing that levels of pretreatment resistance in Southern Africa, Western Africa, Eastern Africa, Asia, and Central and South America is definitely and actually quite rapidly increasing. Of note, as we mentioned, this is of course the levels of pre-treatment NNRTI resistance, and just of course to remember, in most of these regions, patients would be initiated on an NNRTI-based regimen. So data from a study that I'm involved in South Africa, this is in fact a cohort of about 1,200 patients. We're doing sentinel site surveillance of pre-treatment resistance levels. And just to note, okay, so for instance, of those of the interviewing patients in terms of interviews and also in investigating the medical records, and about 10% of those patients that are in fact initiating therapy in South Africa at the moment at our sentinel sites, in fact have been in care before and have received antiretroviral therapy at some point before, either through exposure to PMTCT region, but actually interesting, most of them had been in care and receiving ART for treatment management purposes, had dropped out of the program and are now coming back in again. If we look at the levels of pre-treatment resistance between those with prior exposure versus those without, you can see a very clear difference. So in fact, what we're showing is that 15% of ARV-naive patients in South Africa have pre-treatment resistance, mostly obviously N and RTI, but in fact 37% of them with prior ART exposure have resistance to first-line regimens. Again, why do we need to worry about it? So data from Tamara Bunda very clearly showing that the presence of transmitted resistance at treatment initiation significantly decreases your chance of achieving virological success. This is a study of the PESA study, and was in fact conducted at a number of African sites with 2,500 patients. Whilst interesting, the pre-treatment resistance rates were not that high. They were only 5.5%. In fact, the presence of pre-treatment drug resistance was associated with an adjusted hazard ratio of 3.8 of not achieving virological suppression in first line. Same patterns in children. So if you can see in this bottom graph at them over here, I think this was published by Jordan et al. In CID. Very clear showing that over time, levels of pre-treatment resistance in children are rapidly increasing. This forest plot that we have on the graph over here, this has broken up the studies into children with prior exposure to ART, probably through PMTCT exposure, versus those without. As you can see clearly, 42% of children with prior exposure to PMTCT regimens, in fact, have pre-treatment drug resistance at time of treatment start. What's interestingly enough, in those without prior exposure, again, you can see this definite increase in pre-treatment drug resistance levels over time. So we have here for in 2006 going down all the way to 2013. Summarized at the moment that I think what the number is 13%. So 13% of children that are initiating treatment are initiating with resistance to the drug regimens that they are about to be treated on. So just to of this, the very nice analysis that was done by Andrew Phillips in conjunction with the WHO ResNet team to obviously model, in fact, what the impact of these pre-treatment resistance levels will be. Firstly, in terms of AIDS deaths, new infections, and in fact ART costs. And very interesting, over the next 4 years, this modeling approach that they've adopted has indicated that in fact 135,000 deaths will occur because of drug resistance. If you expand it in fact to the next 15 years, it's almost 1 million. HIV drug resistance alone will in fact be responsible for 105,000 new infections. Again, if you expand it to 2030, 500,000, and probably cost $6.5 billion US dollars if we don't do something about it. So what is the global action plan and response? Again, in 2017, the WHO launched their global action plan on drug resistance. There were 5 key elements to this plan. The first key element was, of course, prioritizing prevention and response to HIV drug resistance levels, including finding mechanisms to improve adherence on patients who are receiving treatment, maximize retention and care, and obviously ensuring that appropriate regimens are being prescribed and that no stockouts occur. The second part of this global action plan was, in fact, of course, to expand viral load testing to all areas, and then possibly even increase frequency of viral load testing, but also more importantly, responding to viral load test results. The WHO has always advocated periodic surveys to measure pre-treatment resistance and acquired resistance, and of course we're using routine data where available to improve the monitoring and surveillance activities. Encouraging research and innovation, finding ways to improve service delivery, and finding diagnostic assays will have maximum public health benefit. Obviously, increasing laboratory testing capacity for both viral load testing and drug resistance testing. And of course, lastly, but more importantly, expanding on governing and enabling mechanisms. So encouraging country ownership of treatment programs, as well as surveillance and monitoring activities, and of course, finding sustainable funding for these activities. So inclusions, I think the take-home messages that I want to just bring across, rates of pre-treatment resistance are definitely increasing quite rapidly. In many low-middle income regions. This is obviously predicted to compromise international efforts to achieve 90% virological suppression targets. Efforts must be made to improve retention and care and maintain virological suppression in patients that are in treatment. Of course, this is coupled by scaling up of viral load testings. I haven't gone into new formulations that are on the horizon, but they certainly are available and are very near on the horizon and should be considered wherever possible. And I'd just like to end as well that I do believe wholeheartedly that HIV drug resistance can be minimized and in fact prevented. Just to acknowledge all my collaborators at South Africa, and thank you for your attention.